Good morning. So today we are going to see about cranial nerves number 4 and 6. Yes, obviously the question arises, where did 5 go? Well, we will be seeing cranial nerve number 5 in a separate session, uh, where because the cranial nerve number 6 is very closely associated in function like the trochlear nerve, that is cranial nerve number 4, which is purely motor. So starting with trochlear nerve, which is cranial nerve number 4, we can see that this cranial nerve is also purely motor, like the cranial nerve number 3. If you recollect, oculomotor nerve was also purely motor. Uh, Here, the trochlear nerve arises from the midbrain. So the only cranial nerves that arise from the midbrain is cranial nerve number 3 and cranial nerve number 4. And the distinct feature of trochlear nerve would be that this is the only cranial nerve which arises from the dorsal aspect of the brainstem. So if you see this diagram, you can note that it comes from the posterior surface of the midbrain. So among all the 10 cranial nerves that is attached to the brainstem, the trochlear nerve is the only one which arises or attaches to the posterior aspect or comes out from the posterior aspect of the brainstem. So that is a very unique, uh, character of the trochlear nerve. Now, coming with regard to its course and distribution, of course, the origin, that is a functional component, would be the general somatic efferent, and in this case the nuclei will be called as trochlear nuclei, which will be seen in the lower level of the midbrain. So that is from where the nerve will arise. So the nuclei will be in the lower level of the midbrain, or that is the trochlear nuclei, and from there it arises from behind. And if you see, that is as it is, uh, as we will see the course, it is the only cranial nerve that exists from behind the brainstem, and then therefore it has to wind and pass across the cerebral peduncles of the midbrain, and then it, as it courses forward, it has to enter the cavernous sinus, just like the oculomotor nerve. So if you recollect, the oculomotor nerve also entered the cavernous sinus through the and passed through the lateral wall of it. Here also we will see the same, but it is of course below the oculomotor nerve, and then it has to exit the cranial fossa through the superior orbital fissure, that meaning it enters into the orbital cavity to supply that extraocular muscle. Now, which is the extraocular muscle that it supplies? It is only going to supply one muscle, and that is superior oblique muscle. Okay, so after it exits through the superior orbital fissure, we have to understand there are a couple of structures which are passing through the superior orbital fissure, because it's a very long fissure. Therefore, for understanding purposes, normally we divide the superior orbital fissure into three compartments, upper, middle, and lower, because of this common tendinous ring which is almost lying in the across the middle of this fissure. So the common tendinous ring is the tendinous interconnection of four uh, extraocular muscles. So, oculomotor nerve is passing through the middle compartment of the superior orbital fissure, whereas the trochlear nerve, which we are now seeing, is passing through the upper compartment of this superior orbital fissure, along with lacrimal nerve and frontal nerve, which are divisions of trigeminal nerve. So the oculomotor is passing in the middle compartment, and trochlear is passing through the upper compartment. Okay, so that is how it enters the orbit to supply the muscle, and it supplies only one muscle, and that is superior oblique muscle. So it's kind of like a VIP muscle, which is getting a sole cranial nerve to supply it. Now, the action of superior oblique muscle is intorsion of eyeball, depression of eyeball, and abduction of eyeball. So, primary action being intorsion of the eyeball, And the nucleus, as we told you, is the trochlear nucleus, which is lying in the tegmentum of the midbrain, the lower level of the tegmentum of the midbrain. Then it comes out through the posterior aspect, and then as it is coming out and passing across the cerebral peduncles, it will pass between this posterior cerebral artery and superior cerebellar arteries, which are very closely related to this nerve. And both these arteries are branches coming out from the basilar artery. And so before it enters the cavernous sinus, it is passing in between these two arteries. And then it passes on the lateral wall of the cavernous sinus, after which it is entering through the superior orbital fissure in the upper compartment along with lacrimal and frontal nerves. And it passes to or passes across the levator palpebrae superioris and the superior rectus muscle to supply the superior obliquus muscle. Okay, so superior obliquus muscle. So the superior obliquus muscle is solely supplied by this trochlear nerve. So in summary, the functional component is general somatic efferent, which is what the trochlear nuclei is. And from there, as we mentioned, in particular, that it passes out from this midbrain through the posterior surface or the dorsal aspect. And then it enters the cavernous sinus and exits the cranial fossa through the superior orbital fissure to supply the only muscle it supplies, that is superior oblique muscle. And the function of the superior oblique is intorsion, depression, and abduction. So applied aspect of trochlear nerve palsy will show inability of the eyeball to move downward and laterally, causing also double vision diplopia and several other associated. Now, very important to understand is the conjugal eye movements also. Now, if the abduction, the trochlear nerve is affected singularly, you will have a medial squint or a convergent squint. The also associated with intracranial pressure increase and double vision, which occurs when looking down. So that would be some of the uh, signs which will be seen when we have a sole injury to the trochlear nerve. Okay, so coming next is the abducens nerve, which is cranial nerve number 6. Now, this is also a purely motor nerve. So, therefore, again, the same general somatic efferent. So, the cranial nerve number 3, cranial nerve number 4, cranial nerve number 6, all of them had general somatic efferent functional component. The only difference is that cranial nerve number 3 had an additional special visceral because it has parasympathetic fibers supplying the intraocular. So now the cranial nerve number 6, that is again another cranial nerve which is there to supply only one muscle, and in this case it is the uh, lateral rectus, again another extraocular muscle. So we can see here that among the extraocular muscles, two extraocular muscles are supplied by uh, cranial nerves singularly. That is cranial nerve number 4, which we just saw supplied superior oblique. And then comes this abducens nerve, which is there to supply only the lateral rectus. So abducens nerve is coming, the nucleus, that is the functional component, that is abducens nucleus, is lying in the pons. So from the pons, the abducent nerve arises from the nuclei. One feature is that it is passing out medially through the pontomedullary groove. So it passes in the pontomedullary groove, and the most medial nerve which passes from that pontomedullary groove is this abducent nerve. Now, this abducens nerve might have a long course, as it is passing through the cavernous sinus again. Just like again we saw the trochlear and the oculomotor, which are also passing through the cavernous sinus. But the difference here is that the cranial abducens nerve is passing not on the wall of the of the cavernous. It is passing along with the internal carotid artery, very closely related to the internal carotid artery, while it is passing through the cavernous sinus, normally posterolateral to the artery. So the abducens nucleus is situated in the tegmentum of the pons, in front of the facial colliculus, and the from the abducent nucleus, the cranial nerve will exit out of the pontomedullary junction, okay, or the groove, and above the pyramid, that is medially, and then it passes upwards and anterolaterally in the subarachnoid space of the posterior cranial fossa. So before it goes straight into the cavernous sinus, there is a slight upturn, and then it passes through the cavernous sinus, where it is passing along with the internal carotid artery. So in this diagram, we can see this abducent nerve coming out of the pons through the pontomedullary junction, and or the groove, and then you can see it is winding up. It is winding up because of the clivus bone which is lying in front, and then it has to pass anteriorly, where it is then entering into the cavernous sinus. So as it is entering the cavernous sinus, you can see it is then lying to be very close to the internal carotid artery here, which is also passing through the cavernous sinus, and then it has to enter the orbit, and therefore it is passing through the superior orbital fissure. Superior orbital fissure. So in this course, we can see it will be lying between the layers of the dura and the petrous temporal bone as it is entering the cavernous sinus. So, and then as in the cavernous sinus, as I mentioned, it will be accompanying the internal carotid artery for a short term of its course, enters the superior orbital fissure, or we can say exits the orbital fissure to uh, reach the orbit. And then it is solely going to supply the muscle called lateral rectus. So this is the course of the abducens nerve. Abducens nerve. Okay, so here you can see where how it is related with internal carotid artery, lying infrolaterally to this internal carotid artery while it is passing in the cavernous sinus. So this is a very important relation for the abducens nerve. It's lying below and lateral to the uh, internal carotid artery. And of course, surrounding the internal carotid artery is also the sympathetic nerve plexus. So therefore, there is a close relation between these two. And as it is passing through the superior orbital fissure, as reminded in the earlier nerve also, we can see the abducent nerve is also passing in the middle compartment, along with the branches of the oculomotor. So the abducens nerve, the superior division of oculomotor, the inferior division of oculomotor, and the nasociliary nerve. These are nerves which are passing along with the abducens in the middle compartment of the superior orbital fissure. So after it enters the orbit, the nerve may divide into smaller divisions or filaments, and it normally supplies the lateral rectus from the aspect of behind the muscle. Okay, so that is its important course. So an important aspect to remember when we talk about muscles movement moving the eyeball is the conjugal eye movements. That is, the right eye and the left eye has to move in coordination. That is called as conjugal eye movements. And for that, we have a higher center, which we call as the lateral gaze center, and the medial gaze center. And this lateral gaze center is very much in coordination with regard to this abducens nerve. So when the lateral rectus of one eyeball moves, the opposite eyeball medial rectus also has to move along with it if you want to have a uniform movements of or a coordinated conjugal movements of the eyeball. So we're not going into the details of it, but just remember there is conjugal eye movements. Lateral gaze center is what coordinates it, and it is being coordinated through the medial longitudinal fasciculus, which is a very long tract which we see in the brainstem. So this medial longitudinal fascicle fibers will coordinate oculomotor, abducent, and trochlear. Therefore, we get a coordinated movement between the left eye and the right eye, which is very important, which explains why the when you have lesions, the movements which may affect one eye may not be affecting the other eye. So these are all in coordination with the higher center's lateral gaze center. Okay, so since the nucleus is lying in the pons, if you have a pontine lesion, you will see abducens nerve affected, you will see facial nerve affected. So we cannot simply say that abducens nerve sign is purely with regard to abducent nucleus. It mostly will be associated with a pontine lesion or a injury affecting the pons. So when you do the clinical testings, so it is mainly when you testing the abducens, you are checking the lateral movement. So abduction of the affected side. That is what we test. So the lateral movement of the eyeball, and at the same time, you may also see the opposite eye, that is the other eye moving medially. So that is what we mean as conjugal eye movement. So different causes of injuries could be tumors affecting the cerebellopontine angle, cavernous sinus lesions, intracranial pressure in general, and mostly affecting is the vascular lesions of the pons. So these may result in abducent lesion also affecting the nucleus or the nerve. So that is the summary of the abducens nerve. General somatic efferent is the functional component. It is lying in the pons. It exits the cranial fossa through the superior orbital fissure middle compartment, and it solely supplies the lateral rectus muscle, the main action being abduction of that eyeball. So this is about the abducens nerve, and I hope you have understood the importance of both trochlear nerve and abducens nerve. Thank you.